As Chairman, ladies and gentlemen, I'm very grateful for the opportunity to speak to you today. I'm Zulfiqar Bhutta. I'm the Chair in Global Child Health and Policy and the founding director of the Institute for Global Health and Development at the Aga Khan University. I've been asked to speak to you about some issues related to nutrition in Pakistan. And what I thought I might do, if I can share my screen, is talk to you about the status of women and child nutrition in Pakistan, particularly with its relationship and implications for policy. So what I would like to do over the next 20 minutes or so is talk to you a little bit about the recent findings from the National Nutrition Survey that took place in 2018, and more recently from the school-age child nutrition surveys of Punjab and Sindh that have not as yet been published but are available in the public space as reports. I'm going to give you 5 key findings from these recent bodies of work and hopefully then talk to you about 5 key actions that we can take in the context of nutrition and sustainable development goals in Pakistan. The National Nutrition Survey 2018 that my team led, this was the 3rd consecutive survey that we've done in Pakistan over the last 20 years, was the largest survey that had been done in the country with district-level specificity. Close to 100,000 households were interviewed, and as you can imagine, the response rate that we were able to achieve, despite all odds, were over 95%. And the sampling frame for this was all over the country, as you can see, and because of the laboratory test that we needed to do, it was based around the network of laboratory pickup points that the Aga Khan University has established across the country. The survey was not only associated with clinical data, dietary intake data, as well as information in relation to determinants of health and nutrition, but also collected micronutrient status, as we had done previously in 2011. In addition, we checked water quality with microbiological and chemical sampling at a household level, and also assessed iodized salt or fortification status in households. The more recent school-age child nutrition survey, which is the first such survey in Pakistan, scans, was undertaken in the 2 provinces of Punjab and Sindh with division-level specificity. And overall, our sample is close to around 5,500 children, with a sampling frame, as you can see, is representative of the population of Sindh and Punjab. And this is a unique survey because it was done at population level, including both children within school and those children who are out of school. So let me now look at the 5 key findings. And our first key finding that is important for public health, nutrition policy makers, and practitioners is that childhood malnutrition rates haven't really changed much over the last half century in Pakistan. You can see this very clearly in this graphic that shows stunting rates and wasting rates. And if you take these stunting rates and take an average of around 50% or thereabouts in the year 2000, there hasn't really been much change over the last several decades. Similarly, wasting rates at a national level have been around 14-15%, which is really very high for a country like Pakistan. But these national averages hide behind them tremendous disparities and subnational differentials in nutrition. And this district map shows you the prevalence of stunting in various districts of Pakistan. And as you can see, more significant levels of stunting are towards the south of the country. And you can see this in terms of regional stunting values in various regions of Pakistan, ranging from about 30 to nearly 50%. The most trends that you see for stunting across provinces do show that there may be a slight improvement in certain areas, notably, importantly, in Khyber Pakhtunkhwa, where you are presumably assembled today. But in several other provinces, rates have plateaued between 2001 and 2018. If you look at wasting trends, on the other hand, we see a very troublesome increase in wasting levels across several provinces. And it is not entirely clear why this is the case. Sindh, in particular, in the south of the country, has seen an increase in childhood wasting in recent years. The most severe, the most deplorable forms of childhood malnutrition are seen in the form of wasting and stunting. This is a map of waste children by districts. As you can see, it's largely clustered towards the south of the country. And if you look at the overlap of stunting and wasting, it is really the same geographies that you see the most worst forms of childhood stunting and wasting, with the most adverse outcomes. As you know, mortality rate amongst children with undernutrition is the highest in children who are both stunted and wasted. And you can see in many districts of the country, this combined proportion of children who are wasted and stunted is in excess of 10-15%. In our school age nutrition data, you see differentials which are in the same direction as what you see in the National Nutrition Survey for children under 5. So these are for children between 5 and 10 years of age. And you can see that in Punjab, overall moderate and severe stunting rates are close to around 20%, whereas that figure for Sindh is around 35%. So we have a real issue with some gradient between urban and rural populations, which is to be expected. But this suggests that the nutrition deficit continues from under 5 children into school-age children. And that's one of the reasons why you have this persisting well into adolescence. The second key finding from this recent work is that there is a very close correlation between maternal and early child undernutrition. Now, this is obvious to students of this particular field. You can see this with the data. These are data for various indicators amongst women who are wasted, underweight, with a BMI of less than 18.5. So whether it's birth weight, low birth weight, stunting, wasting, underweight, everything is much higher in that subgroup of mothers. And you see this also reflected in regional maps. This is the map of women who are underweight or have a body mass index under 18.5, wasted women, largely clustered in the south of Punjab, Sindh, and Balochistan. And if you were to overlap on this, the maps of children who are stunted and wasted together, it is almost the same map. So there is a very close relationship between maternal and child undernutrition in Pakistan, which is very important for policy. The third key finding I want to share with you is that there is an enormous opportunity to improve infant and young child nutrition in Pakistan, reflected through the lens of both promotion of breastfeeding as well as complementary feeding. And I'm going to show you some recent data on this as well. Firstly, on breastfeeding, there is a tremendous depreciation of exclusive breastfeeding by age. So although about 2/3, 3/4 of our children are exclusively breastfed early, this should be much higher. But the depreciation from this by 6 months of age is tremendous. Only about 1/3 of these children are exclusively breastfed or so by 6 months of age, which is the requirement and which is the recommendation. But the most depressing and important thing to note is that if you look at a simple indicator of children, young infants, who are never breastfed at all or don't receive the mother's milk, that proportion in many provinces is close to around 1/5, 20%, and in some cases even higher. Now, you really cannot imagine such an important public health intervention being so loosely implemented or not implemented in Pakistan. And this is a major issue that increases the deficit in terms of child health and nutrition very early on. Then we have other indicators for complementary feeding that we have traditionally looked at over the years. This is the rate of exclusive breastfeeding. It is not something clustered in the south of the country. As you can see, this is all over. So this is not a practice only restricted to the malnourished areas. It's all over, including parts of Punjab, including KP. And if you look at minimum dietary diversity in children under 2 years of age, which is how much varied diets that they have during complementary feeding period, many of them have very little dietary diversity. They receive very poor quality foods. Now, I looked at this another way, and I looked at the relationship of the type of feeds that these or food that these children were receiving between 6 and 24 months of age, under 2 years of age, in various surveys of the country. This is, I think, multiple indicator cluster surveys, serially in Punjab, between 2010 and 2018. And I looked at growth rates. So here it is stunting rates for children who are receiving different types of foods. And just to point out to you importantly that there is no difference. Even breastfed children, children who are receiving ideally breastfed and complementary foods, have actually higher rates of stunting. And some of these children who are receiving mixed feeds are slightly better, but these confidence intervals all overlap. So what it shows is that universally, in many of these children, most likely the complementary food quality is very poor. And therefore, between 6 and 24 months of age, they're not getting adequate diets in children that we have seen. You see the same in Sindh, the variations a bit more, but you see overall also that even children who are breastfed or receiving mixed feedings, their malnutrition rates with stunting being about 40 to 50%. And this hasn't changed dramatically over the last 20 years or so. The fourth key finding that I want to share with you is that it is important for us to focus on primary care programs. Now, which primary care programs are we talking about? Well, the most common one that we have is Lady Health Workers Program. So if you look at within the Lady Health Workers Program and overall, as to what is the nutritional status of children whose mothers received antenatal care, and it's very clear that those who received 4 or more visits through the Lady Health Workers have the lowest malnutrition rates, whether they are for low birth weight, stunting, wasting, underweight, etc. So it's very clear if you improve maternal care in pregnancy, consequent impact on postnatal or young child nutrition are very positive. You see this also in the intake of iron folic acid during pregnancy. Those who received it largely through the primary care program had lower rates of low birth weight, stunting, wasting, and underweight. So these programs do matter, and it is important for us to scale them up to a large extent as much as possible in our primary care programs. The final key finding is the most worrying. And this is the finding on Pakistan now facing a triple burden of malnutrition. Now, remember, all of our nutrition surveys largely focus on women and young children. So we as yet don't have data on elderly, middle-aged people. Otherwise, this would be a much greater marker. But let's look at the data that we have on the relationship of undernutrition with overnutrition, with overweight and obesity, and also whether or not there is a triple burden of both overweight and micronutrient deficiencies and undernutrition in the country. So first of all, overweight and obesity in children under 5, thankfully in Pakistan, is uncommon. If you take overweight and take obesity rates, you can see that prevalence rates are very low in general. This is not a big issue, but it changes very rapidly. And by the time they are adolescents, these are data for adolescent girls that we have from the National Nutrition Survey, overweight is just generally very rampant. And obesity also emerges in the bucket. Now notice that this is not necessarily in the richest parts of the country. This is appearing in some of your poorest population. I'll show you some data on that in a minute. By the time they get to adult life, women of reproductive age, this is data from the National Nutrition Survey, these are adult women. Overweight is almost universal in terms of high prevalence rates, 15, 16, 20%. And if you look at obesity, now you see it clustered in some of the richer parts of the country like northern Punjab. So there is a change, a secular change in overweight and obesity risks. You see this clearly in terms of current patterns for overweight and obesity in women of reproductive age. If you take both together, you're talking about this being much higher than women being wasted. So if you take underweight rates in Punjab of 12% women being underweight, you're looking at around 41% women being overweight and obesity. And my worry is that these obesity rates of 10, 15% are amongst the highest that we see in the region. Now, I was interested to see where are these trends coming from. So we calculated between 2011 and 2018, based on our survey sample, by asset quintiles, by poverty levels. Where is this increase in overweight and obesity taking place? And as you can see, for obesity, You see this in the poorest populations also. You see it in the middle populations also. And you see it in the rich as well. But the rich are not necessarily those that have had the greatest BMI change. It is actually the poorest who have had the greatest change in obesity. Same with overweight. So therefore, this is not a problem of the rich only. This is happening amongst the poorest of the poor as well. Why? Because nature of diets and risk factors have changed. Do we see any reflection of that in the school age population? We are beginning to see some of that as I speak to you. And I've already talked to you about underweight. This is BMI data. For children between 5 and 10 years of age, from our SCAN survey, you can see that already in many parts of the country, we are beginning to see overweight and obesity. In Punjab, close to around 10%, and in Sindh, again, close to around 7 to 8%. So this is growing, and this is cause for great concern. Does it relate to micronutrient deficiencies? You can see this very clearly. If you take the anemia prevalence in women of reproductive age and iron deficiency anemia, there are many pockets of our population where this is as high as 15–20%. When you look at our urban and rural population, these micronutrient deficiencies, such as anemia, is widely prevalent in both, and there is not a major difference between the rich and the poor. You see 37–47%, 37–50% in our rural population. Then that tells us that micronutrient intake, even amongst the relatively well-off, is lower than what you would anticipate. And you see this also reflected in BMI categories, that some of the women who are overweight or obese also have prevalence rates of iron deficiency anemia of 14–15% and anemia of about 30–39%. So this is widely prevalent across all risk groups, and that's why we call it a triple burden. You see this reflected in children also. This is 5 to 10 years old. It's the first time we've got anemia data for this age group. In Punjab, that figure is 30-some%. In Sindh, between urban and rural populations, that figure is around 45–50%. So half of our children are anemic. What are they going to learn in this school population if they have deficits in learning because of anemia, half of which at least is iron deficiency anemia? So let me conclude and move on to my key messages and learning. Firstly, as you can see from here, maternal and child malnutrition in Pakistan is multifactorial. It's related to complex socioeconomic, cultural, and behavioral determinants, and also related to environmental risk factors. While, it affects children in extreme poverty and food insecurity, you also see this cut across socioeconomic strata. So we have a universal problem in which we have quality issues as well as issues related to undernutrition. This triple burden is one of our biggest emerging problems. So take it from me, this is what we will have to deal with the forthcoming epidemic of non-communicable diseases, and this will affect Pakistan's human capital. I think I've already shown you more data than we have ever been able to show before. We have enough data by district, by region, and you can see by distribution in Pakistan. So we do not necessarily need more information, but we need is better analysis of the information and the political will now to do something about it at scale, which I hope that conferences like yourselves will try and address. We need a nutrition action plan at national level. We've never had one. We've had some programs at PC1s, but we've never had a nutrition strategy at a national level, which is firmly owned by the provinces and by all sectors, both health and non-health sectors. The second set of recommendations that I have, key actions, is that nutrition actions start outside of nutrition. It's very important that we invest in this, and we invest in this in the long run. This is not enough by itself, but these investments are necessary. Education and empowerment of our population, especially girls and women. Take away early marriage. These girls are disadvantaged. They're malnourished. Their growth is not complete. You can't have children having children who are then going to be at risk of undernutrition. That also means you have to take care of rampant population growth and address family planning, principally as a means of improving maternal nutrition and health. You cannot do this. I don't have time today to go into the water, sanitation, hygiene, but just imagine that around 80% of our water is not fit for consumption. And you cannot have proper growth with such a contaminated environment. We need social safety nets, and here Pakistan has a great opportunity because we have a cash transfer program. Now we have a program called Sehat Sahulat in many places, which offers curative services. It needs to reposition itself to also offer preventive services and reach marginalized populations. The second set of major actions for health is within the health and nutrition sectors by improving maternal nutrition and micronutrient interventions. Exclusive breastfeeding needs to be supported by everybody. We've just had the World Breastfeeding Day and Week, and this is a real tragedy in Pakistan because commercial determinants of health have influenced this in a big way. I've already shown you how our complementary diets are so poor that irrespective of the protective effect of breastfeeding, the complementary foods are not enough to prevent growth, retardation, and depreciation. So we really need complementary strategies, which include fortified low-cost supplementary foods that need to be developed and community education in terms of improving nutrition outcomes. I hope you're going to discuss fortification programs. This is the real future. We got rid of iodine deficiency largely through iodized salt, a fortification program. My late grandfather, may Allah rest his soul in Jannah, he was a civil surgeon. He spent all his life in the frontier in some of the remotest areas of Bhutta and in Gilgit and Chitral. And his specialty was what, my friends? He is specialized in the surgery of joint goiters. That was his specialty. And he was recognized for that in the entire region. He published papers in the British Journal of Surgery. Today, we don't see that. They have disappeared, these giant goiters. Why? Because we have had a universal iodization program that has gradually permeated into the population and led to change. So when we want to, we can do this. And we can do this much better in terms of iron fortification of wheat, vitamin A supplementation and fortification of products. And obviously, we need to address what is emerging from our recent data on the priority to be given to school-age children and addressing undernutrition at that age. Why? Because you want them to grow up to be better educated, healthy, well-nourished adolescents and then adults. Within the nutrition sector, there is a need to improve the repertoire or the package of nutrition interventions that we have. And I think one of the most important components of that package is complementary feeding. So I hope some of you will have a chance to discuss how we can produce better quality complementary foods for use by poor populations and children who can receive those with appropriate micronutrient supplements. Reaching the poorest of the poor through some of the strategies that I've talked about requires targeting. And one of those means is also to improve public health nutrition outreach. Now, I hope that you will discuss agriculture as well. We need to improve the quality of our agricultural products through biofortification and through also addressing some of the impact of climate change. Very few of you know that climate change affects micronutrient concentration of many crops, particularly wheat and some of our own staples. And therefore, we need to counteract that through appropriate research and agriculture strategies. This cannot be done without ownership, political ownership. There was ownership of the ESAS program in the previous government. We need to improve that even further with tying in the nutrition components to ESAS, the ESAS National Numa program, to make sure that we are able to reach the poorest of the poor through this. And we need to develop a pilot school health and nutrition program in the very provinces that we have generated the data for this being a public health crisis. Lastly, I've shown you the data. I produce and I analyze this information largely for advocacy. We need to have a means of monitoring this in real time, of increasing accountability, and of holding our provincial and district health and nutrition staff to account for some of the lack of change that we have. This strict monitoring and evaluation requires the creation of a district-level nutrition dashboard, which does not require surveys every 5-6 years, that you can look at that data in real time and see what's happening to low birth weight rates, how many babies are being weighed within 24 hours of birth, what is happening to maternal anemia rates when they are coming for antenatal care. Without that monitoring and evaluation, you will have no finger on the pulse of public health until you do another survey in 4 or 5 years costing millions of dollars. We need to integrate nutrition within programs. And one of my pet projects right now is to look at how you can integrate nutrition within routine immunization services or surveys that or outreach programs that we have currently, where you have tremendous potential. I've talked about Nashwa Nama already, but I would like to see the development of an annual nutrition report in Pakistan, not one survey every 5 years. We should produce an annual dashboard which tells us exactly what we have done and not, and maybe organizations like yourselves, annual meetings like yourselves, would be able to look at this in greater detail. I want to thank you for your attention. I am very sorry I could not join you in person in this meeting. I've just returned from Pakistan from a trip, so I could not return back so quickly. But I hope that you will have an ample opportunity for deliberations. And if my presentation has set the scene for where the challenges lie, I would have done my job. Thank you very much for your attention.